Today, our conversation is about opioids. And we are very happy and honored to have two guests with us, two chiefs of police from Arlington and from Gloucester. And the thing that I can say about them is that they are innovative, they are visionaries, they are leaders. And indeed, as we think about people who are addressing the issue of opioids, I'm so very impressed with the things that they're doing and glad that they are here. Professor Rosenblum is going to be our moderator for today, and I'm going to let him now introduce our guest.
Thank you very much, Harold, and welcome to you all. There's still seats down here, so come collect seats. It's my great personal pleasure to welcome Chiefs Campanello and Ryan to the School of Public Health this afternoon. They are the leaders of a rapidly growing movement in Massachusetts and around the country of police-assisted addiction recovery initiatives. Today, there are 88 police departments in 22 states that have signed up to cooperate in this program and to replicate in one way or another the objective of helping people with substance use disorders from opioid addiction get into treatment instead of incarceration. We're going to proceed in two quick steps today. The first, Dr. Davida Schiff is going to report on the beginnings of taking a look at who's coming in to the Gloucester program, what they're doing, and what's happening, at least on a very interim basis. And then Chiefs Campanello, Ryan, and I are going to have a conversation, which will then be rapidly followed by questions and comments from all of you. I am not going to spend the next hour introducing them in any detail because that would ruin the substance of my first question to them. So, Dr. Schiff.
Thank you all. I apologize in advance for my voice. I'm just getting over a cold. So I have the honor of getting to share the preliminary results of the hard work of Chief Campanello and his team at Gloucester. And so I'll just cut to the chase and sort of tell you what they've been able to accomplish. So since the program started on June 1st of 2015, there have been 387 total visits between June and February 15th. There's been 352 total unique participants who have come through the program, with 24 coming through the program at least twice, and 5 who've come for 3 or more visits. We asked where are the participants coming from, and 60 of the participants reported an address within the Gloucester zip code, and 62 reported to be currently homeless. So what this looks like, if you look at a map of Massachusetts, is really participants who are coming from all over the state. That's Gloucester. I wanted to give you a sense of how the participants who are coming through Gloucester look compared to some other available data for all Massachusetts substance abuse treatment program admissions for the year 2014. As you can see that they're roughly 2/3 male, which is pretty consistent with other statewide programs. The participants coming through Gloucester are more educated than the data that we have from the statewide, that about 36% of them have greater than a high school education. If we take a look, the majority of the participants are single, never married, which goes along with their mean age being slightly younger than the statewide data. And then, interestingly, the percent unemployed is significantly lower than the statewide data for substance abuse treatment admissions across the state. So for this slide, I just want to really call to your attention the data on the last opioid use for the participants who are coming through the program. About 85% have used either the day that they come in or the day before, necessitating their need for detoxification before treatment. If we asked the average age when they started using drugs was 15.5 years, and the average age when they started using opioids was about 20.5 years. participants were asked how they heard about the Gloucester program. And about a third of them had heard through a family member or a friend, and the other half had really heard through some form of either online social media. I think part of this story is going to be a story of Facebook, which Chief Campanello will share with you, and then traditional news media and radio. Another question that is asked to the participants is, why did they decide to come to the Gloucester Police Department now? Our attempt to summarize the varied responses really shows that many individuals just feel like they need help. They've hit rock bottom. They're trying to get clean and sober. They want their family, their children back, and they have had enough. So this is a graph of where individuals have been placed as time progresses. As you can see, as the program started, I think another important story that we'll likely hear from Chief Campanello is that the red diamonds represent individuals who've been placed at Spectrum, and the relationship that the Gloucester Police Department developed with that treatment program and the number of individuals that were able to be placed at that program. Finally, I wanted to just tease you with a little bit of follow-up information that we're just starting to do as the second part of our data analysis, which is what's happened to the participants once they've come through the program. We've just started to make our calls with a team of really dedicated medical students. 177 of those 387 participants visits who've come through have been contacted. 177 of the participants have so far been contacted. 47 participants have been reached, which gives us about a 26% response rate currently. And a really interesting story of those 47 who've been reached. The numbers don't do it justice. I think the stories of their time through their treatment, their time and the arc of their treatment with relapse, with struggles to stay clean, that I think the chiefs will be able to describe from their interactions dealing with the individuals is more telling. But the numbers, 35 of the 47 that we spoke to, we're currently not using. 9 of the 47 that answered were currently using. There was one individual that was currently incarcerated, and only 2 of the 47 chose not to participate.
Thank you very, very much. And now I'd like to invite Chiefs Ryan and Campanello up, and we'll start our discussion. Thank you.
You weren't waiting for me, were you?
Welcome to BU. I'd like to start by asking you each of you to tell a little bit about yourselves and a little bit about the experiences that brought you to your current beliefs about addiction and the proper role of police chiefs in dealing with this, because you're playing a little bit out of character. So what is it that you think about your experience brought you to this point?
So in my circumstance, I work very closely with our Department of Health and Human Services, which is directed by a woman who's a graduate of this program. So she has been very instrumental in enlightening me. However, shortly after Chief Campanello and his leadership rolled out their program, and it became pretty publicized early on, what happened with me was I was briefed on a drug investigation, a drug trafficker, who we know had sold drugs to 2 of our victims of fatal overdoses. And our drug control officers gave me a very detailed briefing, operation and tactical briefing, on how they were going to arrest this major drug supplier. And after the briefing, I asked 2 very simple questions. Do we know the identities of those buying their drugs from this dealer, their heroin from this dealer? The answer was yes. And the follow-up question was, what are we doing to get these people services? And the answer was nothing. So what I took away from that was the police department, through our well-intentioned efforts, we're creating a public health crisis in the community, because the next day we have a known population of people suffering from substance use disorder who we've just taken their supply off the streets. And we were doing nothing but waiting for them to go and find a new dealer. So from that was born the Arlington program shortly after the Gloucester model. Clearly, Chief Campanello triggered the out-of-the-box thinking. But now any enforcement plan, such as the one that I got back then, comes with a parallel public health plan to deal with the known population of those suffering from substance use disorders in our community.
Chief?
Thank you, David. And before, I'll take 2 minutes just to be a little anecdotal, because you know me. I have my master's from BU, so I'm an alumni.
Very important, very important.
So, for all you professors who I may know out there who said fat, drunk, and stupid was no way to go through life, you wrote me off too soon. And just an aside on David, the recent legislation that was passed, a great benefit to starting this program was being able to meet some really pioneering and great people. The culmination of David's work with BU and with Parry resulted in the language you see from the bill that the governor signed, whether or not anybody else admits it, is primarily words from David's mouth. Yeah. And, you know, I am honored to call him a colleague as well as a friend. He has been an inspiration to me and a lot of us chiefs who do this type of work now. So thank you, David, for everything. For me, it's a slightly different arc than Chief Ryan. As you kind of grow up in your profession in policing, you go from, there's really no oversight. You're a police officer in a car, and you go out and you do your job, and you use a lot of your discretion, and you go ahead and make your decisions solely on what you feel is the right or wrong thing to do. As you start to gain some managerial responsibility, you realize, if you're any good at what you do, that your responsibilities to others grow even further. And when you get to sit in the big chair, your responsibility to the community, despite your own ideas about law enforcement and about the criminal justice system, are much more important than your own personal feelings about what should be done. So even if I did not believe in this approach, which I believe wholeheartedly, the idea that I was responsible for reflecting the community's wishes, and the community had told us, we don't want you arresting people with a disease anymore if you don't have to. We want you to help. And so born out of that was the Gloucester model. And seeing death was also one of the main reasons over many years. Seeing death in large numbers and kind of in law enforcement going, well, that's not what we do, we arrest, led to this change. The coupling of that with really being responsible to a community's ideas and how they wanted their police department to operate.
The programs that you've actually created are a little bit different. So what is it that you're doing?
The Gloucester model intakes people, and Chief Ryan will describe the outreach that his department does. Our approach was three-tiered. For the purposes of today, I think the most provocative and probably the one that everybody has heard of is the Angel Initiative, in which we invited people who were suffering from the disease of addiction to come into the police department with or without their drugs and not face any prosecution, any solicitation of information, any degradation, any stigmatization, to come in and we would try to assist you into treatment. That was our guarantee. That was our promise. If you came in, if you asked for help, we were going to give it to you. And the basic premise of that is what's carried us to today, and the statistics that were shown to you. It's really kind of taken off quite a bit. It's in a lot of different police departments around the country. We partner with several hundred treatment centers. It was that simple idea, that we were going to offer you help if you came to us first. I think.
Yeah, and in Arlington, it's sort of the flip of that, the sort of a push-pull model. We do the outreach with a known population of addicts in our community. And they're identified through 3 different sources. One through, as I mentioned earlier, through criminal investigations of dealers. We learn the identities of those who are buying. Also through our 911 calls for response to overdoses, where officers and first responders are delivering naloxone. And thirdly, through good old-fashioned community policing. The beat cops know who's using in their beat. And so through those relationships and sort of through those 3 silos, we have a known population of those suffering from substance use disorders in our community. So we have a clinician embedded in the police department who does outreach to these folks and works with them and their families to develop an intervention plan moving forward.
And these are the 2 general models that are being adopted around the country by police departments. And one of the things that's happening around the country is as they contact the organization that's been created to support these programs, the chiefs themselves or members of their staff are providing technical assistance and training for the police chiefs and people who are beginning to operate these programs around the country. How do your programs differ from what else is going on in the criminal justice system? And I know that there's been some pushback from other elements in the criminal justice system that are also trying to get people into treatment. So in what ways are you different and similar from the rest of what's going on in the drug courts, the diversion programs, and all those things that have been around for a little bit?
There's an intangible piece of this, and it's stigma. It's the fact that self-stigmatization and then the stigmatization from the community at large and from people who operate in positions that would be considered authoritative, police, medical professionals, DAs, the courts. We're very, I think I speak for Chief Ryan, but I'll let him speak for himself, is we're very anti-coercion, anti-incentive for this disease. If you want help, there are no strings attached. You don't have to have a charge that's hanging over your head and pick one or the other. You cannot put someone's child in front of them and say, quit this disease or we're going to take your child away from you, and expect them to quit. So how is a charge of possession of an illegal substance going to incentivize someone to give up their disease? It doesn't happen. You would not arrest a cancer patient to get them help. And so while I applaud the efforts that are being made through the court system, I don't believe it does anything to address the stigmatization. In fact, I think it makes it harder for the person who wants to get recovery once they're done to have a criminal record and then go try to find a job or go try to find a way to reintegrate back into society. So if we can catch these people before they commit crimes, before they use again, if we can catch them and reintegrate them into society or give them an opportunity to do so, then we're really not only helping the individual, but we're helping our neighborhoods, we're helping our community by having another viable member of the community to get out there to work, to pay taxes, to not do crime, and to live a very life filled with quality.
Yeah, and the only thing I would add to that is that, I would argue that there's institutional stigma, right? So Chief Campanello and I roll out our programs. We get pushback from prosecutors and others arguing, you don't have the discretion to do what you're doing. And I said, hold on, let me think about that. For decades, under the so-called war on drugs, we've been taking somebody who possesses drugs, making promises to them, listen, we won't charge you with a crime, but you tell us who your dealer is, and then we'll bust your dealer, and then the prosecutors run off and prosecute a case. That's discretion, right? We now apply that very same discretion. Hey, you go into treatment, and I won't charge you with a crime. And prosecutors are saying, not so sure you have the authority to do what you're doing. It's the stigma associated with addiction that's driving those type of comments and decisions. Lenny and I have been very strong at pushing back on that. We argue we do have the discretion to do what we're doing, and by and large, those that have pushed back have sort of stepped aside, and we continue to march and do what we do. But the stigma piece is a huge challenge. The other piece of our program that I didn't mention is twice a month we have community meetings, and then twice a year we do community-wide meetings. And we were talking earlier, and you know, addressing stigma is such a challenge. And I would argue that it has to be done neighborhood by neighborhood, community by community. And you know, in Arlington, when I stood in front of a town hall full of about 500 people, and a convicted felon and former addict stood up, and I hugged him and embraced his recovery, you know, the optics of that sending a message that if the police chief can hug a felon, the community can hug a felon and welcome him back into the community as he fights his addiction and moves on his recovery. But the stigma piece is a huge challenge for us. I think the same thing in Gloucester.
So one of the things that Davida showed on the slides was that a very substantial percentage of the people coming in learned about this through social media. She said this was going to be the Facebook program. What's that all about?
So I know all of you are young. Most of you in the room are young.
And you're not.
No, I'm not. I'm younger than Fred, but he'll argue that I'm much heavier, so we even out. So you're all on Facebook, Snapchat, did that, Twitter, whatever. I don't even know all. My experience with Facebook before the Gloucester Police Post was, when it first came out, I said, wow, this is kind of nice. I wonder how this works. And I tapped in my information. And about 20 minutes later, I got a private message from a girlfriend in high school. And I said, there's a reason why we're not married. And the reason is because I stopped liking you in high school, and I hit delete, and that was the last time Leonard Campanello was on Facebook. So, but I think, again, you know, your responsibility in these positions you get is to utilize different avenues to educate and to make people aware of what you're planning to do. And in this case, the power of social media was overwhelming. Our first Facebook post, before we actually held a community forum in which we announced our plan, which we just said, look, we've had 4 deaths in the city, we hate it, you know, we want to help, what can we do? Got 39,000 hits. That's 10,000 more than the people, the population of Gloucester. Our second Facebook post, about a month and a half later, hit 2.5 million people when we announced our program. It was shared 30,000 times to another projected 30 million people in all 50 states and 61 countries by Facebook's metrics. So when you have Uzbekistan reading your Facebook post of the little North Shore city that is, you know, stuck in a corner on an island, you kind of get to know how social media plays in this. And you also get a very, very clear picture of exactly how important this issue is to so many people. It allows people to almost anonymously say, you know what, I know someone who has a problem with this, or I have a family member who has a problem with this. I can respond to this on social media in an instantaneous way and share my story with everybody and join that collective voice. So we had millions of people who were interested in this right away, and it gave us a very, very clear idea of how important this issue was and how pervasive it was in the entire nation.
Was your picture on that Facebook post? I couldn't resist.
I'm doing really good with the 55 to 65-year-old demographic of women who are really into compassionate fat guys. I'm really into that.
I didn't say it. It's a public health crisis right here before our very eyes.
I'm never going to be as old as you, Fred.
But the reality is, by the way, that following each major Facebook or other social media post, or following each of the many news stories that have been generated by the program, more people come into the station. And so, in fact, there's been a direct and continual response to people coming in, asking for help, in direct response to these social media posts. So, which raises the question that I've had since the beginning of all of this. What is so cockamamie, crazy, opaque about getting help for the disease of addiction that people would be flocking to police stations where they could be arrested? So give us a sense of what you guys see in the treatment system as you now begin to interface with it a lot more than you ever did before.
Well, one major frustration we had is that emergency rooms simply didn't have the desire or the capacity to deal with somebody coming in through the ER after having overdosed. And in several instances that we're able to track, the very patient that had been treated for an overdose, hours later went out and succumbed to a fatal overdose. The system was failing these people. And so that as our program unfolded, you know, we're now dispatching a clinician on an overdose to the ER because we don't have confidence that the ER is going to manage that case to the best situation for the patient. So that was a huge frustration for us. And as we began to do that, and as, you know, through the social media, and as it became quite apparent to the community that the police department was no longer interested in arresting people with substance use disorders, we're getting calls after hours from family members, roommates, partners, parents of a loved one in crisis with an overdose, to the point where we had one situation where the police department facilitated control use of opiates while we worked to get the person placed. It's just become an amazing phenomenon.
And we find, you know, that there's an inherent trust that the police and the public have that's been lost a lot in the last few years, more and more so even in the last 5 years. But it remains, and it remains the police department's or law enforcement's responsibility to rebuild that trust. We can't sit on the other side of the fence and wait for someone in the public to say, let's rebuild the trust between police and public. We have to do it ourselves. Emergency rooms have lost the trust. Physicians, to a certain degree, right, wrong, or indifferent, have lost the trust of individuals, because upwards of 80% of the people that we see addicted to heroin started with a legally prescribed pill. And so going back to a doctor when you need help for an overdose, there's a little skepticism there on the part of the addicted person. And when we started our program, there was a lot of distrust. This was like the free boat auction, right? You know, where police department's giving away a free boat. Here's your ticket in the mail, and we're sending them out to all people with warrants so they can come in and get arrested on their warrant. So we had to prove ourselves that we were going to stand by our word, and we were damned if we were going to go back on our word after building trust. And that trust was reciprocated after a very, very short time that this program was up and running. And I think there is an inherent trust there, and when you prove it, people naturally respond to it.
And I think, if I may, Professor, you know, last year about 950 people were shot by police in America. About 900 of those were violent armed felons where the police really had no other choice. About 50 of them fall into the gray area. Many of those you could debate all day long. And it's changed the view of police in America because of a few of those isolated cases that occurred. How many cases of malpractice were there last year? Alleged malpractice, 500,000? Do we have people, do we have this stigma that medical doctors and physicians are somehow intentionally harming their patients? No, of course they're not. Well, police aren't intentionally harming violent felons in America either. So my point is when you apply that sort of, you know, those 50 cases that have changed the image of police, it illustrates really the power of perception among police that we have in our communities. And so leveraging that power to applying it to addressing those with substance use disorders has been, it's just been exponential. And Lenny can talk about treatment centers who would tell a healthcare professional they don't have a bed, and Lenny or his staff calls them, and because it's the police chief calling, all of a sudden there's a bed. We don't know why, but we might as well use that to our advantage, right?
Indeed. So you can start posing as police chiefs. Now, let me turn to you. You all came. Many of you probably came with questions or curiosities. So if you have questions, why don't you get into the conversation? Bill? I think there's a microphone coming in your direction.
Hi. The question I wanted to ask had to do with treatment capacity, because one of the concerns I would have as this idea catches on is that there's not enough investment in making treatment available to keep up with the demand that you're creating. So I wonder if you could say a little bit about whatever efforts you've made in that direction to complement what you're doing in working with other police departments.
So the first thing I would say is, and I want you to just explore this answer because it's not meant to be offensive in any way, but how is that the police department's problem? You know, we're facilitating treatment. We expect other entities to come up with the solutions of where the treatment is. But having said that, and you can digest that for whatever it's worth, is that treatment, you know, we say bed like it's the concrete four-stand mattress in a room someplace in inpatient as the end-all be-all of treatment. When there are, and we were speaking a lot about this before we got in here, there are literally hundreds of different ways to assist someone in addiction. And we think a very powerful way, and we've happened to find, in Gloucester, we've happened to find a bed for every single person that's walked in. But even if we didn't, we would form a connection with that person. And based on what a clinician told us was their best course of action, if that could not be facilitated right away, we would stay connected with that person and say, hey, look, the treatment isn't here right away, but we're here for you. You know, if you're in a bad environment, we'd like to help you with that. If you need a support call, we'll help you with that. The power of that very tangible connection goes a long way, and I think it's something that we overlook. And we also have to get away from the feeling that a bed is the only place to put someone who's in addiction. Because no, if 351 communities in Massachusetts adopted this program tomorrow, there would be no capacity to put every single person in a bed. But we would have the capacity to have one person or one avenue of treatment open to that person and just connect and say, look, we're not forgetting about you. We know you have addiction. We now have your name and number. We're going to stay in touch with you until that treatment is available. And we can work on the system as we go along. But it can't be a choice between detox or you get nothing. It has to be something in between.
And many of our intervention plans involve medication-assisted treatment, outpatient type treatment as well. So it's not all inpatient approach.
Is that Rich back there?
Yeah. When in the healthcare system, when we refer people, the few times that we successfully refer people to treatment, we make it very complicated. It takes a lot of time and effort, and we do these assessments, and we make a lot of phone calls. I'm wondering if when you do that, does it take a whole lot of time? Does it take a lot of time and effort? And if it does take a lot of time and effort for you, are you annoyed by that you're having to do our jobs?
Well, you know,
He had to jump in.
I've been doing your job for so long.
we only wish we were paid as well as you. We were talking earlier about some of the self-imposed barriers. Lenny has a great story. Why don't you tell it again? He already forgot it. It must have been nonsense. So a patient didn't have a 30-day supply of meds?
Right. Okay, do you want me to finish it?
Yeah, please. So he also has a little dementia early on. We're gonna
Public health crisis.
Yeah.
So to answer the specific question is, you know, we're not out to disparage anybody. We're not out to point the finger. clinicians have an incredibly difficult job, and it is not rewarding at all, especially when it comes to substance abuse, because what happens is invariably a clinician is attached to a hospital group, and that hospital group has a certain number of detox facilities that they work with. And there's a list, a very real list that people go down, and they call the numbers. No, 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 no. And that clinician has 10 other people to visit in 7 different sites in their radius. They can't stay there for 2 hours and work. What we do is we're open 24 hours, 7 days a week. 24 days, 7 weeks a year.
I rest my case.
So what our ability is that if there's not a bed at 10 o'clock in the morning, we can call again at 10:10 or 10:20 to our facilities that aren't associated with hospital groups that are grown to 3 times the size of a clinician's list. And if we don't find a bed on the first or a treatment option on the first go-around, we keep calling. And typically, believe it or not, probably true for the last 200 we've had through the door, it's under 2 hours to get someone from our front door walking into the back door, walking to a treatment facility. And the barriers that are up that we ask about, and it's sort of it's a cat and mouse game because we have no idea what we're talking about when we talk to treatment. So how the hell would we know anything about treatment or the conditions or what DPH has as standards? We don't do that stuff. But because we're the police, and we do this in a lot of investigations, we wink our way through everything, like we know what we're talking about. So we inherently, because we're the police,
He speaks for himself.
No, I don't. We inherently, because we're an authority figure, inherently we're given a certain bit of latitude on what we know. So we'll call someone up and they'll say, look, and we'll struggle with them for 3 or 4 hours, and they'll say, everything's great, except we have a condition that if you don't have a 30-day supply of pills, of your pills or whatever it is, you can't get in. And they only have 18 days. And we say, well, why can't we work on that in the 18-day time frame you have now? And they'll say, it's just one of our conditions. And we'll say, just like you would if you were 12, I'm calling Ma. We say, I'm calling DPH. And they say, oh, we'll take them right away. And that's just one, that's an example of using, I think, for lack of a better word, and not trying to sound pompous, but our clout in law enforcement to sort of not change the whole system, but to get people thinking that extra step about, what are we really doing? What can we do? What can't we do? So I think that's why we've been successful, is because we don't stop calling and we ask very 3-year-old-like questions, which always begin with why.
And then Sally.
Hi. One idea that's gaining a lot of traction in fighting the opioid epidemic are safe injection facilities, and which are facilities where injection drug users can inject pre-obtained illicit drugs under medical supervision. And as far as I know, I believe there are about 90 facilities currently up and running around the world in Australia, Germany, Sweden, and one in North America in Vancouver. So I was wondering if you could shed a little bit of light upon how you and your fellow police chiefs would, how would you receive the possibility of opening a safe injection facility in Massachusetts? Thank you.
So I think it's a double-edged sword. I think it's a slippery slope on one hand. On the other hand, I think that if you don't have any other option, and Fred actually has a story about this, and I'll remind you of it, Fred.
I have a clear, vivid memory of it.
Would be one of the only things. I think there are circumstances where that will work, but I think there has to be a caveat if we're going to sanction that we don't have the capacity to treat you right now, but we don't want to leave you alone, just like we were talking about a little earlier. I don't know that that's the road we want to go down. I'm certainly personally open to hearing a lot more about it, but I don't know if that's something that we would definitely blanket, agree with. I think it's a slippery slope. But here's a great example.
Yeah, on a case-by-case basis with somebody, an individual who's in crisis, rather than have a family member throw them out of the home because they're under the influence of an opiate and using in the home, which is the natural reaction of a parent. You know, you stop using or you're out of here. That's really putting the patient at risk, right? So we're trying to turn that on its head and say, you know, keep them in the home. Here's your naloxone kit. We'll train you on using naloxone. We're going to go to work at getting the patient placed. So on a case-by-case basis, for a very short window of time.
And there has to be a really clear distinction here that we're not condoning the illegal use of a drug. We're not saying you should legalize anything. But we are recognizing the public health crisis far outweighing the need for us to be arresting people in these situations.
Right, and the alternative is arrest this young man, bring him to court, through the revolving door, pay the $45 fee to get bailed, and they're using again in 2 hours. You know, so clearly that model doesn't work.
Very quickly, if I could follow up. So, what do you think is at the bottom of the slope? Like you keep referring to the
ISIS.
slippery. ISIS. Wonderful.
He's having another moment.
It's got to be. That's what the feds want us to believe is behind everything.
Sally.
Hi, thank you for coming. Very interesting, and we appreciate you spending the afternoon with us. Very often people who suffer from problems with addiction also have mental health problems. And I was wondering if you could speak to your experiences around that. Do you think of this as really only an addiction problem, or do you also have ideas about how to help people with mental health problems and addiction problems get into treatment?
Well, in Arlington, our clinician is funded through a DMH grant, a jail diversion co-responder model. As we embedded a clinician into the police department, it was primarily to help police officers deal with people in crisis with mental health issues. And quickly, the intersection between mental health and substance abuse became abundantly clear to us. And now her role is primarily dealing with the combination of the two. You're absolutely correct. And she co-responds with police officers. 2 scenes, 1 scenes have been stabilized.
There's a lot of work to be done in law enforcement with mental health. Matter of fact, ironically, our efforts in Gloucester to connect with people with mental health issues has met with much more resistance than the addiction community. And I think addiction and mental health are the chicken and the egg, right? Which came first? So, and there's so many more of us who suffer from some sort, on any end of the spectrum, from some sort of mental illness. If you're counting depression and anxiety, just count me in. You know what I mean? Because all of us are on some form of spectrum, so we have to start accepting that.
That too?
And Gloucester.
Somebody call 911.
Your stock up here is going down quickly. So what we started in Gloucester was a Safe Watch program. And what it was is we wanted to reach out to the community, caregivers, guardians, parents of people with mental illness, with a very comprehensive and private questionnaire. Not only name, address, conditions, medications, things like that, but key de-escalation words, places we could take people, so that when we encountered someone with a mental illness that we had identified through our Safe Watch program, we could pull all this stuff up before the officer got into an encounter that does turn violent and deadly sometimes. We didn't get a lot of takers for that because, again, I think we have a stigma issue there, and I think we have a very private issue going on. But yeah, we have a long way to go there too.
First, and then, is it Ronnie back there? Okay.
All right, well, thank you guys for coming. Just to start, though, I am an Iraqi-American who grew up in Boston, so I can firmly debunk the whole ISIS thing, for sure.
Good deal. Thank you.
But I came when I was a year old. I grew up in Somerville, and then we moved out to Woburn, and you could actually see geographically, when town to town, the towns that were deeply affected. And I actually went to Arlington Catholic High School. And I remember on the first day of my sophomore year, the principal pulled us all in, and we were all wondering why he was so mad, calling us all losers, saying we were the worst class to ever come through AC. And we're all trying to really rack our brains to think why. You know, there were no more fights than there were the year before. Just as many kids were doing it, but we realized there were a few kids in that first year, acutely when we were freshmen, that were caught selling opiates, and it was a huge problem. And the ironic part is that I noticed that about half the class, the kids who weren't directly affected by it, kids from other, suburban neighborhoods, they didn't really care. But when it started to spread later on in high school, years go by, now I see these kids all over Facebook using social media. A few of my friends started the Black Balloon Day, where, if you know somebody who was affected or something like that. And I guess what I want to ask was, you mentioned the stigma in the state, but having grown up with parents in the pharmaceutical and biotech industry, I know that we're not like the largest producers of opiates or anything. We're more a research-based community here, but it's still, it was always frustrating for me to see that we had such incredible capabilities, but we couldn't connect the policies locally. And we're a family in the state. People are very close. People know one another, and people want the community-level effort. But what kind of, I guess, encouragement would you give to local health departments as well as local community members to try to beat the stigma and try to help people out of it? Because no town wants to say, we welcome our addicts. Nobody wants to do that. But there are towns, as you guys have done, that have been brave enough to really set the standard, and you guys have gotten an amazing response, and I'm really proud of you guys for that, so kudos there.
I think that, so yeah, no community welcomes their addicts. I think we're going to turn that around. I think, I'm not sure exactly, I think adding the legitimacy of the voice of different entities, in this case law enforcement, added a degree of legitimacy saying that addiction is a disease, and we were going to change how we were viewing the addict themselves, and also addiction played a key role. But awareness, getting people to respond. This is so pervasive now that there aren't too many people who haven't been affected by it. And, getting it out of the closet, so to speak, and getting it into the air and into the light is going to do so much more for the disease itself, and destigmatizing it for those who aren't involved at all or don't have a family member at all. That the ways to do that, I think there are as many ways as there are people in the community. It is a matter of kind of, dealing with that age-old problem of just, it's easier to just turn and walk away from something than it is to try to understand it and identify with it.
And if you apply some of the reentry models and the research that have been done around prisoner reentry, we can set people up for failure, give them a scarlet letter, call them an addict. The likelihood of them reusing goes up exponentially versus reentry programs that set people up for success. Used to be we let people out of prison, we didn't give them a job, we didn't give them a house, and then when they reoffended, we were surprised by that. Shocking. And so the programs that have succeeded are you give them a job, you give them a house, and you give them somebody invested in their success. If they don't have a family member, an angel from Gloucester, whatever, somebody invested in their success, the research is abundantly clear that the likelihood of a successful recovery goes up exponentially.
And that's your Johan Hari chasing the scream part of it. He makes, if you haven't heard or seen Johan Hari, he's a, I don't know exactly what it was, a producer or something in the entertainment, not entertainment, but he was a researcher, documentarian.
Another
or something.
Moment.
You're only here because I'm here. Okay.
Wow.
So
I was here, I just came for the free lunch. So.
Johan Hari, Chasing the Scream, is his book. He has a TED Talk that I would encourage you all to watch. And in the last 10 minutes or so of his TED Talk, he talks about almost the most important piece of this is the reconnection with society. Because heroin takes everything away from you. It takes your connection to your family. It'll take your kids right from underneath you. It'll take your job away, your house away, your self-esteem away. And if you don't find a way after you've recovered, if society doesn't welcome you back and say, okay, you know what, we have a job for you if you'd like it, if you're willing to work. We have an opportunity for you if you're willing to take it. If there's no connections built there, they're 50 times more likely to disappear into that hole again. And so it's a very important piece of the puzzle. And it's a responsibility. this is a very, very big issue for both Fred and I, is that, a lot of people tout this as an achievement. There's no achievement in this whatsoever. This is a responsibility, not only for every human being, but more so for people who would choose to be police officers. This is what we're supposed to be doing. We're supposed to be helping people, especially those with a disease. And if that means thinking outside the box, then that too is a responsibility. There is no achievement here. So if the police can have that kind of connectivity to their community and to individuals, then yes, why can't we turn to one another and do the same thing?
And the
offer some
data early on is abundantly clear. You saw Gloucester's data in Arlington in the first half of calendar 15. We had 1 overdose fatal per month in the first half of the calendar year. We implemented our program in July. From July until February of 16, in this calendar year, we had 1 fatal overdose. So, addressing stigma, tackling this as a community saves lives.
Ronnie and then Eric.
You've described some amazing ways in which you are changing the conversation about.
You're talking about me, not him, right?
Both,
Oh, okay.
both of you, changing the conversation around addiction. But one piece that you haven't mentioned is your conversations with the pharmaceutical industry, and I was wondering if you could talk about those experiences and if you thought they were effective or what other strategies need to be done.
I can sum it up in 2 words, and one of them I can't use here. So, and the other one is them. So you can figure it out. They have, we've spoken with Purdue, with Pfizer, and with the big steroid using older brother pharma who protects them from when the nasty police officers come and ask them pointed questions about what they're doing in the area that they created. And they have I am convinced that they have no desire at all to be a part of the equation of solving this problem. They have no desire to admit to any wrongdoing, even though my feeling is that they would be embraced, that their sins of the past would be forgiven, and they wouldn't be embraced for doing the right thing now. But they're so stuck behind the 150 lawyers that they have and that always goes well when you have a team of lawyers deciding your humanitarian efforts. I can't think of a moment in history where that hasn't gone well. But I think that they're so stuck listening to their attorneys about don't mention anything about this, that, and the other thing. They have no perception of what's going on. And, I've said it before publicly. I use the word treason when I talk to them. And treason, you think of Napoleon. I was going to say dynamite, but of Napoleon Bonaparte. But treason.
Now he's going to teach us history.
Treason is a. That's the last comment. Is a betrayal of someone's trust as well. And I think they've betrayed the trust of the entire nation with what they've done. And they have no desire to fix it. We don't need them. We don't need them. We're just going to take money out of their pockets now.
And we just need to be cautious. There are some companies developing good drugs, medication-assisted drugs for opiate addiction.
Pharmaceutical.
No.
We're just about, I apologize, we're just about out of time. So let me abuse my role here and ask one closing question. We're in the midst of this natural experiment of what you guys are doing. What do you think is the most important thing you've learned so far?
Not to sit around and study it and form committees and task force and groups of just do it. The bodies were turning up. I know we couldn't continue to see that trend. We capture all the data on our overdoses. We had one beautiful young lady, overdose. Week later, overdose, Narcan both times. Second time transported to an area hospital emergency room, 7 hours later, overdose fatal. That was predictable, that was going to result in a fatal overdose, and if it's predictable, it's preventable. Just do it. Don't study it. Damn the torpedoes and do it.
And I think that recovery is a reality for a lot of people. I could fill the rest of the open seats in this auditorium with recovered addicts, and you wouldn't know the difference between yourself or your family members or the persons. that were recovered. Yeah, we all make choices. When that choice becomes a disease, we have a responsibility to help, just like it was diabetes or cancer. And the recovery from that is a possibility. It's a reality that can happen, and people can be brought back to life, literally and metaphorically. We have the tools, we have the capabilities now. We just have to do it. We can't sit around in committees. We got to do it.
Well, I want to thank you both for coming.
Thank you for having us.
The work that you're doing is truly going to change the lives of the people who encounter your programs, but change the lives of many others who will benefit because the program is spreading. And so for that, we thank you as well.
Thank you, Doctor.
Thank you, David.